Welcome to the Promoting the Urinary Continence conference call. My name is Nicole, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Liz Dominguez. Ms. Dominguez, you may begin.
Thank you. Good afternoon, and welcome to today's webinar presented by Lake Superior Quality Innovation Network. LSQIN represents Empro in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. Continuing nursing education credit and a certificate of attendance will be offered for this webinar, and the link to the evaluation has been provided in the chat box. Because Metastar is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speaker has reported no conflicts of interest, and there are no planner conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. We encourage everyone to complete the evaluation to provide feedback on the session. And now I'd like to introduce you to today's speaker, Kelly Cruz. Ms. Cruz has over 35 years of experience that includes public and community health, internal medicine, women's health, and a specialization in continence management. She has maintained national board certification as a nurse practitioner since 1986 and has 20 years experience teaching at the undergraduate and graduate levels as a clinical associate professor for the UW School of Nursing. She has received distinguished faculty recognition from the National Collaborative for Stress, Urinary Incontinence, and Women's Health. She is also the owner of Urogyne Consultations, an independent nursing consultation practice specific to the management of urinary incontinence, pelvic floor health, and gynecologic care, and often provides services related to F315, continence, UTIs, and catheter use. And at this time, I'd like to turn it over to our speaker, Kelly.
Thank you so much. And thank all of you for attending today. This is a topic that you can tell I really feel passionate about. And I have a funny story to tell you. I didn't always feel that way. I went to a conference probably 20 years ago now, and I couldn't get into the session that I wanted. And so as a result, all that was left was for me to go to a topic on urinary incontinence, and I was really a negative person about that. I think I behaved badly. And I have to tell you that once I got in there, within 5 minutes, I was like, oh my gosh, this is such an important issue. I learned so much. It changed so much of my thinking about it. I realized that I really came to the table with a lot of just misperceptions, and now I'm pretty passionate about managing continence as a way to contribute to an improved quality of life and dignity for our older adult population. So I wanted to start off today by just sharing with you that there is, in fact, an International Continence Society, and not everybody is aware of that, and it won't surprise you that I probably am one of those people who has attending that big national meeting on my bucket list. But it's important to recognize that this is a worldwide problem, and it's not just a problem that is specific to nursing homes in the United States. However, all of you are in a really unique position to be able to demonstrate through your nursing skills and knowledge and ability to help people live a much more comfortable and continence-managed way of life. And I think that's a really terrific thing that nurses can bring to the table. The International Continence Society defines incontinence as an involuntary loss of urine, which is objectively demonstrable, and a social or hygienic problem. And those of us who work with that issue would agree with this completely. What I do want you to take away from this slide is that the development of urinary incontinence is a symptom. It is not a disease process in itself, but rather a symptom that often is a result of other factors. And should I do anything with that? Keep going. And as a result of other factors, what we're going to talk about in just a few minutes. The other thing that I want to provide you with real clarity on is that the development of urinary incontinence is not an inevitable part of aging, and we have a lot of older adults and, quote, old adults who go on to come to the end of their lives having never developed bladder problems. And so it's important to recognize that you are working with a unique population, and that oftentimes because of their changes in function or their multiple chronic illnesses, it may seem like that the development of urinary incontinence is inevitable. The other piece that I want you to take from this slide is that there's always something you can do. You may not be able to fully reverse it. You may not be able to cure it, but there is always a way that you can put a management plan in place that will really contribute to an improved quality of life. So as I mentioned, the incidence of incontinence is high throughout the world, and in the United States it affects more than 17 million Americans. That number is probably even greater now since we have baby boomers turning 65, 10,000 a day on a daily basis, and many of them with chronic multiple illnesses that are predisposing them or putting them at risk for bladder problems. It is more common in women than in men, and we do see an unusually high incidence in long-term care, as well as adults who are homebound or who are receiving caregiving at home. It does increase as people move past the age of 65, and one of the things that I'm sure you've noticed in your own practices is that urinary incontinence and falls are the leading reasons for nursing home admissions. Oftentimes people think that changes in cognition are the number one reason, but the evidence really shows us clearly that when you can no longer manage elimination needs at home effectively and that the risk of falling goes up, that it's very difficult for caregivers to want to continue caring for them at home. So when we look at some of the evidence that kind of set this course of this action into motion, we know that there's been some very specific research, and one of the landmark studies was done by Nancy Watson and colleagues, specifically in long-term care. And when she evaluated this, one of the things that she found is that half of the residents were incontinent of urine. The interesting part about this is that within 3 months after being admitted, the other 50% of residents who were continent had gone on, 25% of them had gone on to develop urinary incontinence. And so now you're up to 75 to 80% of residents struggling with some sort of continence issue in long-term care. I think that this has remained pretty consistent. And one of the big takeaways for that is that out of all of those patients, only about 15% of residents are routinely assessed for issues related to bladder function incontinence. And out of those, only 1 to 3% are receiving any treatment or management plan. Interestingly, though, almost 100%, 99% of residents are all wearing absorbent products. And so while what I'll say to you today is that absorbent products are one of our tools, it's not the only tool, and I hope that you're going to come away with sort of more tools in your toolbox to be able to individualize continence care plans for the elders that you care for. This is also an issue in community dwelling settings, assisted living as an example. And these numbers have actually been projected as being low, but they do vary because it's very hard to get good reporting. But you can see 15 to 30% remains pretty consistent. So why do we care about bladder function? Why do we care whether or not somebody's continent? Well, urinary incontinence is significantly related to the development of other comorbidities. And so those comorbidities include depression, isolation, and you may see this in your residents. They quit going to lunch. They quit going out for family activities or social activities. They lack confidence in those situations, and as a result, they become somewhat withdrawn, and it has an impact on their overall sense of self. We also recognize that unmanaged urinary incontinence contributes to skin breakdown. Pressure ulcers are the thing that we think of most commonly, but the reality is incontinence-associated dermatitis is much more common and is often being incorrectly treated as a yeast infection in long-term care settings. And so being able to really engage fully in a better understanding of good skin care and reducing that breakdown and using continence as a way to help improve that situation is important. Urinary tract infections, which is a whole topic in itself, but certainly changes in not only the structural and anatomical parts of the body, including for women the urethra, as well as changes in the bladder neck and the bladder itself. For men, enlarged prostates come into play with that, all of those contributing to urinary tract infections. And finally, falls and fall-related injuries are significantly related to UI. And if you think about that, many of our residents are falling on the way to the bathroom either because they're rushing because of urgency or fear of becoming incontinent, or because they're leaking or losing urine on the way to the bathroom and they slip and fall. So some really important things to really keep in mind that when you're addressing continence, you're also addressing all of these other connected issues. And so when you think about the MVS as an example on your quarterly assessment, I would encourage you to think about that if you have a change in any of these other areas, you also need to be assessing what's happening with the bladder in general. So this is a really expensive problem. $16 to $26 billion is spent annually on UI. To give you an example, Hurricane Katrina, the cost estimated with that were at about $14 billion, and the issues related to urinary incontinence are dramatically even more than that. About 55% of the money is spent on pads and laundry, and about 44%, so about half and half, are spent on adverse consequences of UI, the comorbidities we just talked about, but then also think about hip fracture and some of those other related problems that come into play. And sadly, only 1% of these dollars is actually spent on evaluation and management of this particular health problem. So one of the big questions that I want you to always be thinking about is, why are expenses for evaluation and management so low? Why aren't we doing more? And who's supposed to be doing this? And that's what I want to talk a little bit more about today, because continence is really a team approach, and nurses certainly have a significant role to play. We've always recognized as nurses that incontinence is a health concern, but we've not always had the confidence or the knowledge to address this more fully. And it's not unusual for nurses to traditionally think about continence management as the role of a nurse specialist like myself or a urologist. What I'm saying to you is that this is really beginning to change. And as more and more older adults come into our settings with more knowledge and more information and less tolerance for being incontinent, I do think that consumer demand is also going to really make us pay attention or respond to this problem more fully. Primary care providers have done a really similar thing. You know, when I think about primary care providers, I'm thinking about physicians, I'm thinking about nurse practitioners, I'm thinking about physician assistants. We learn about the problem of incontinence. We don't necessarily spend a lot of time in our education and training really fully understanding the types of management plans and the consequences. And so this is something that's changing in educational preparation right now. Typically, the most common response is for primary care providers to refer to somebody like me or to urology. And so, again, I think we're going to start to see that shift, but it's important to know where we're at right now. Now, Medicare sees this as a significant issue, and as a result, there are specific survey or guidances related to this. And certainly in the long-term care survey, as well as the quality measures that have been identified, these issues have been addressed, and quality of life has definitely been linked or really made more visible by the implementation of strong quality measures. Many of you, if not all of you, are familiar with F315, the guidance on urinary incontinence, urinary tract infections, and catheter use. This went into effect in 2005, and when I say went into effect, it was actually revised in 2005. And one of the things I really like about this particular guidance, not only did my colleagues have input, so this came from nurses who were committed to improving the management of continence in long-term care, but it's also predicated very strongly on the current evidence. And so the goal is not only to improve care, but also to reduce costs. And so when you have a chance to look at that guidance, and if you never have, I would really encourage you to do so because it does a nice job of laying out and focusing on identifying incontinence in the nursing home resident, assessment and evaluation, the key components that are part of that piece, developing an individualized treatment plan, and then being able to implement nursing interventions. And there are lots of things that nurses can do that are under the purview of nursing that don't require orders for us to be able to improve this problem. So in summary, over the past 20 to 30 years, many advances have been made in the treatment of incontinence. The problem is more is known about the treatment than is actually currently being applied in practice. And so what I want to share with you today are some proactive approaches as well as some strategies that you can hopefully take back and put into your practices in the long-term care settings that you're working in. I talked about this a little bit. Certainly caregiver and clinicians have limited or insufficient knowledge of bladder function and incontinence, but we also have the issue that patients are often reluctant to discuss this problem. Many of them are fearful, they're embarrassed, they're worried that they're going to be thought of negatively or they won't receive the care that they need. And again, there's a lack of individualized care. If you think about the different care plans and the patients that you care for, the residents you care for every single day, nobody's the same. And as a result, that should translate into your continence management plan. While you may have common threads in each management plan, there should not be a cookie-cutter continence care plan. How's that? You should be able to individualize that based on some of the factors that we're going to talk about in a few minutes. So as we begin this discussion, I want to thread this in with common misperceptions that we often have about bladder problems in frail older adults. And the first one I talked about a little bit, but that incontinence is inevitable with age. And one of the things that we all can agree on is that older adults, particularly frail older adults, are at an increased risk for incontinence. And a lot of that has to do with the complex chronic illnesses that they come to us with for care. And these impact dramatically on their kidney function as well as their bladder function. And some of these are changes that occur in response to aging. For example, they may experience a dulled first urge. When you think about ourselves when we need to go to the bathroom, we usually get that little message in the back of our brains when we're busy doing things that we might need to go to the bathroom in a few minutes. And if we don't take time to go then, we have another few minutes before we get a stronger message that says you might want to go now, and then if you wait too long, oh my gosh, you've got a must urge on your hands and you're rushing to the bathroom. Well, for our older adults, that first urge becomes dulled. And so that can be a really frustrating situation in long-term care settings because we want them to put their lights on sooner so that we can get in there to help them in time. But it's important to recognize that that dulled first urge is something that's being impacted by their chronic illnesses or their aging processes, and they may not have that as strongly as they once did. And so this is an example of how you can take your toileting plan and tailor that a little bit more in as far as following a more scheduled voiding pattern in an attempt to compensate for that. Another example with kidney function is there's so much going on for frail older adults during the day that when they finally lay down to rest at night and the body's quiet, the kidneys go, oh my gosh, this is my chance. I'm going to take care of everything I wasn't able to do this, throughout the day. And so urine output becomes greater the first 2 to 3 hours after frail older adults go to bed. Well, if you know that, you can tailor your toileting plans accordingly and do some proactive voiding where you can talk with them about waking them up ahead of time, or you can make another decision with them, particularly if they are really struggling with fatigue. You may have some older adults who make a personal decision that they want to be toileted less at night. And so if that's the case, then you're individualizing that toileting plan in the evening to include an absorbent product that can then compensate for that and support their rest and protect their skin. So that's just an example of a couple real key things, but it's something that people don't know a lot about, and once you start knowing that and thinking about that, it does help you be able to individualize care plans a little bit more. So there's many interventions, and the idea is that often we can prevent, many times we can slow the progress, and on really good days we get a chance to reverse it or resolve it completely. So the second myth that comes along is that there's only one type of incontinence. And those of us that have been around patients who struggle with bladder problems, you realize that they all present really very differently. The end result is that they're all wet, but how they presented and the symptoms leading up to that make a big difference in helping you identify what type of incontinence that they have. And so again, having the same plan of care for every incontinent patient is not going to work if you don't have a better understanding of what their bladder symptoms are so that you can more proactively anticipate or manage those. So let's just take a minute and talk about the most common type. I want to say a few things about transient UI. This is something that appears very suddenly. So when your residents who've been continent and then all of a sudden they're not, this is a red flag for you because this is a change of condition and you really need to figure out what's going on. And sadly, and this study has been replicated, but that 80% of the time there are potentially reversible causes of incontinence that aren't being evaluated or assessed fully. And that is a nursing assessment role. And so one of the things that I want you to think about when you see someone who has a change in continence status is what are the factors that could be contributing? How can we manage this or what can we do to treat this? So oftentimes it's related to a restriction or a change in their mobility. There may be a change in their fluid intake, or there may have been dosage changes or medications added or taken away that are contributing to this problem. The big thing that I want you to know about this is that the sooner transient incontinence is identified, the more easily it is to reverse it and to get an effective management plan in place. The longer that it goes on, the more difficult it is to be able to reverse that completely. The prognosis then becomes impacted for that resident. So being able to identify transient UI is really significant, and consider that a change of condition. This is a quick acronym that you can use. There's lots of them. This one I actually find to be the less offensive than some of them. I never use the diapers one, and I'm sure you've all seen that. But what you're trying to do is cue yourself as to what are the things that I don't want to miss. Well, you certainly don't want to miss that there's been a change in cognition. And diapers is listed here under D because sometimes people become incontinent because they're suddenly being given absorbent products when they don't need them. And so that's a good reinforcement that that's not how we want to do care. And I'll talk a little bit more about the role of absorbent products as far as when they're to be used and how to use those in a few minutes. Think about restrictions in mobility or changes in function. Certainly urinary retention can contribute to this, where you have people who've been continent and all of a sudden they have big gushes or big large volumes of urine loss. Because the amount of volume in the bladder now overpowers the ability of the internal sphincter to be able to stay shut, and there's just a sudden release. Infection, impaction, inflammation, dietary irritants can all contribute to a change in continence status, as well as changes in pharmaceuticals or medications, and polyuria related to chronic conditions. So I want to say a couple things about overactive bladder. We can't turn on the TV, right, without the Viagra commercials and the overactive bladder commercials. But it is important as far as being able to illustrate why it is such a significant issue. Overactive bladder may or may not have incontinence associated with it, and we'll talk a little bit more about those symptoms in a minute. But this is the most common type of urinary incontinence in older adults. And women who are no longer producing menopause, have moved past and have moved into menopause, are particularly at risk for this. It has to do with the fact that the changes in the decline in their estrogen level, they no longer have the same amount of estrogen to keep the urethra, the internal and external urethral sphincters, and the vaginal tissue plump. And so as a result, they often will leak, or they will have urine drop down from the bladder into the urethra that causes that sense of urgency or frequency. We also see overactive bladder symptoms in people with neurologic conditions like strokes, like Parkinson's, for example. And what happens there is that the bladder starts to act in a very uncoordinated way, and the messaging changes. And so as a result, they become very symptomatic. There's often involuntary urination after this feeling an urgent need to void. These residents tend to lose urine before they get to the toilet, and no matter how hard they try, they have a great deal of difficulty suppressing the need to urinate. So it becomes an urgent situation. International Continence Society defines urgency with and without incontinence, usually with frequency and nocturia, and this just gives you those definitions. But urgency is that sudden, compelling desire to pass urine, and it's really difficult to deter. Urge UI is the involuntary leakage of urine accompanied by or immediately preceded by urgency. So this can be somebody that loses a little bit of urine on the way to the toilet, or somebody who has complete urine loss. And then frequency is this feeling like you've got to, you just went to the bathroom and now you feel like you sit down and you've got to get up and go again. And we see a lot of frequency in long-term care settings for a variety of reasons. And then nocturia is waking up one or more times at night to void. What I would say to you is that in our frail, older population, it's very normal to get up 1 to 2 times a night to go to the bathroom. Any more than that, you really need to be concerned about safety as well as quality of sleep. Stress UI is the most common type of incontinence found in women prior to menopause. We see this a lot with athletes, dancers, runners. We see this related to childbirth and postpartum women. But we also see it with men who've had prostatectomy or radiation due to prostate surgery. And in both of those situations, they experience urine loss because of an increase in the intra-abdominal pressure. So think about getting up from a chair. Think about taking a coughing or sneezing. Those kinds of really common things often will trigger leaking or loss of urine. And again, for women, it's often related to a shorter urethra and a change in the pelvic muscle tone. Now, this doesn't mean just because it's more common in younger and premenopausal women, it doesn't mean that stress UI still isn't seen in frail older women, because it often is seen in conjunction with not only a loss of function and functional UI because they're not getting up and moving anymore. So as a result, once they decline their activity levels and they stop walking, they are much more likely to experience weakness in the pelvic floor that then leads to this involuntary leaking. And this may even be patients or residents that you see that you just go to turn them in bed and they leak urine. And that is a pretty significant indicator for a lax pelvic floor and stress urinary incontinence. Overflow UI, or urinary retention, is related to a urine loss because the bladders become over-distended and all of a sudden it just releases. Sometimes we'll see this come out as small amounts or dribbling, but most often somebody's either in retention and incredibly uncomfortable, or they have a sudden loss of urine. And there's lots of causes for that, but the most common cause is hard stool, so constipation or fecal impaction, and an enlarged prostate in men. And so being able to check for both of those things becomes really important. But also taking a look at the medication list, because if somebody is receiving muscle relaxants, particularly smooth muscle relaxants, the bladder is a smooth muscle. So now all of a sudden it's not contracting in the way that it normally does, and it's becoming very lax and letting the bladder overfill with urine. We also see this impaired ability to contract in residents who have peripheral neuropathy. So think about diabetic patients as being particularly at risk for this over time. This visual just kind of lets you see here that there's some blockage down here at the intrinsic urethral sphincter, and so as a result it can't relax in a way that it normally does, and there's a lot of pressure and discomfort and distension occurring. This becomes problematic when it occurs repeatedly or over time, because that urine will then reflux into the ureters up into the kidneys and can put patients at risk for severe infection as well as damage. So it's something that we definitely want to be able to address and be aware of. Stress incontinence, this just shows you the urethra is just very relaxed and open. Those tissues just are not as plump as they used to be, and so as a result, urine can leak pretty easily. And this really represents sort of this uncoordinated way that the bladder's receiving its messages from the brain and the spinal cord, and as a result, experiencing urine loss. So sometimes the visual helps me. Functional UI is an ICD-10 code. It is something that we really need to pay attention to. It's this inability to reach the toilet because there's either environmental barriers, there's physical limitations, there's a loss of memory, or the resident is disoriented. And so when someone has functional UI, they are dependent on other people to help them toilet appropriately. And we certainly have higher rates of functional incontinence in our long-term care settings. Mixed UI is when you have two or more types of incontinence, and it's not unusual. My big three that I tend to document a lot on the patients the residents that I assess are stress UI, urge UI, and functional UI, and they all form a little family together, but they are the most common ones that you are going to see in your setting. Less common is reflex incontinence. That's where there's been a spinal cord injury or some autonomic disruption. Total incontinence really has to do with anatomical malformations or some surgical trauma that is causing that problem. We don't see that quite as much. So, myth number 3, there are no effective treatments for UI. It's unavoidable in our long-term care residents. You already know that I'm going to dispute that right out of the gate, because there's a lot of evidence that shows that incontinence is very treatable in both community and long-term care settings. And nurses working in those settings really have the ability to capitalize on behavioral interventions that include toileting regimes, bladder and urge innovation and retraining, fluid management, and bowel plans that address constipation. You also have the ability to preserve mobility and function, and that includes walking as well as toileting, and the idea of restorative or core strength. Pelvic muscle exercises are something that we can talk about as we get going here, but this is something that cognitively able residents who are motivated do get a good response to. And then interventions that will help you treat and manage contributing factors, whether they're related to the environment, clothing, assistive toileting devices that are needed, or the right kind of product. And then certainly knowing when to consult and referral. Very commonly for vaginal estrogen replacement, the use of different incontinence devices, including pessaries, and medication management for BPH and urge urinary incontinence are appropriate. UI falls under the purview of the physician. That's definitely a myth. There's not much nurses can do to help. In fact, what I find is in the long-term care settings that I work with, that the nursing staff, that we've taken the initiative to put some very proactive things in place, and it is really well received and very well supported by the physicians. And what actually has happened is a very positive team approach has come out of that, and there's more dialogue going back and forth and a sharing of expertise. So it is a fact that incontinence can be managed by non-pharmacologic treatments, and I do want to say to you that really the only two conditions that respond to medication are overactive bladder and urge UI, as well as enlarged prostate. So stress UI does not respond. It's really important and functional UI does not respond to these medications. Our medications are specific to those conditions. Keep in mind that through our nursing histories, our identification of risk factors, implementation of assessment tools that include 3-day bladder diaries, you really have the ability to provide foundational information and be able to begin to identify not only the type of incontinence that a resident has, but also behavioral strategies that can be implemented. Myth number 5, that UI is unmanageable in people with dementia. Keep in mind that although incontinence is often concurrent with dementia, dementia does not cause incontinence per se. So there's nothing physiologically. What it does is it interferes with the person's ability to understand that they need to toilet or to remember where the toilet is. But I have a lot of patients with residents with cognitive impairment who are very clear with me that they are not interested in being incontinent or wet, and they don't like it. So this is where really being able to do prompted voiding comes into play, because that person needs to be prompted as far as where to go, when to go, and then certainly the role of positive reinforcement into the success so that toileting plan will be able to continue. But we have very good evidence that prompted voiding improves dry episodes in long-term care settings. Myth number 6 is that complete continence is the only indication of successful treatment. And I learned this the hard way early on. In one of the facilities I was consulting with, they gave me all of the residents who were in end-stage chronic illness with really intractable incontinence. And they did that as a way to sort of prove that they were right and that continence couldn't be managed in long-term care. Well, needless to say, I stuck with that, and we turned that around. But there is oftentimes an all or none way of thinking. And so what you need to understand is that while occasionally we are able to achieve full continence, what we're really trying to do is improve the situation and reassure residents that we are going to help them manage this so that they can remain socially confident and comfortable with their management plan. This is also really, really important for family and for caregivers as well. And so success can be defined by lots of different things, including dryness at night or during the day. I gave the example to you earlier where we have residents who maybe do pretty well during the day, but then as evening comes, they're much more likely to experience bladder symptoms or wet episodes. This has a combination to do with most likely their energy level for toileting as the day comes to an end, fatigue factors, as well as just kidney function changes in general. But we can also track, using our bladder diaries, fewer episodes of incontinence, a greater percentage of dry time, and an increase in the number of times that somebody urinates in the toilet. All of those are really good examples of outcomes that we can achieve. And so once you start to really capture that, you can really see how management plans can be individualized. And we look at success just really much more realistically, that it's not an all or none situation, but in fact an improvement in how we're managing and contributing to someone's quality of life. Myth number 7, older adults don't mind being incontinent and wearing pads. I don't know about you, but if you came to my house for the weekend and I had laid out for you in my guest room a toothbrush and a bar of soap and a washcloth and a towel, and then I put a big Depends there on the top of it, I'm thinking you might go, wow, people don't go to the bathroom at Kelly's house. I guess we use these pads. I say that tongue-in-cheek, but you don't know how many times that's been the message that has been received by residents who are continent or who have bladder problems that can be managed, but they're only being offered this particular management option. And so again, this may be one of the tools that you use, but it's not the only tool. And keep in mind that we have well-founded evidence that shows that really incontinence represents a loss of control. And, you know, in our residents who struggle with anger issues, you really want to take a look at that. It's not unusual for frail older adults to not only be grieving the loss of independence, but also grieving the loss of their continence status and to feel more embarrassed, ashamed, or depressed. And many will hide their UI from their family members because they're afraid that they're going to be placed in a nursing home. Or we all have residents that even once they're in our long-term care settings, they're hiding their incontinence from us because they're afraid that they're going to be treated differently or they're embarrassed. So it's a significant problem, and it's one that we really want to continually be aware of as having an impact on depression and social isolation and behavioral issues. What compounds this is that incontinence pads are often referred to as diapers within our long-term care settings. And the stereotype and the implication of that is really very degrading to older adults. This is a dignity issue, and when we use the word diaper, it really talks about or implies that they're very childlike and that they've lost control. Now, we do have some older adults that wear pads or absorbent products to enhance a feeling of security. But others do it because they haven't really been presented with other options. So it's just really important to be clear about why and how you're using an absorbent product. And again, as I mentioned, the routine use of absorbent products with continence residents it communicates an expectation that we want them to be incontinent, and really that's considered a breach of nursing ethics. Myth number 8, indwelling catheters are the best intervention for intractable UI. I hear this periodically, and while it certainly seems like a possibility as far as helping to keep people dry and protect their skin, particularly if you're worried about sapping issues, this, however, is not, the evidence does not support this as an appropriate use of an indwelling catheter. The risks far outweigh the benefits. And one of the things that this is really a whole nother talk, but while the intentions may be good, there are significant consequences that are accompanying indwelling urinary catheters. And so as a result, I want you to have other things to do besides that. Myth 9, prevention is possible. This is something that we don't always think about, but you have a real opportunity here to foster continence in your long-term care settings and to foster that as the norm. And so one of the ways that you can do that is really focusing on the person's functional abilities. The longer that you can keep them moving and active and participating in their activities of daily living, the better their continence status is going to be. And as they have functional changes, which is not uncommon with the chronic illnesses that they have. Just think about arthritis alone as an example. But being able then to be creative in how else we do that. So maybe they're not walking as far or as often as they used to. Maybe they're using their wheelchair more often. But are they still engaging in exercise twice daily? Do they still have visible bathrooms available to them? Do they have support to toilet at regular intervals? And according to their own voiding patterns. Is their clothing easy to manage, and are the CNAs receptive and involved in their plan of care to support their continence? I think that most facilities do a pretty good job of trying to have the necessary equipment, including standing lifts, but also really making sure that hygiene is being addressed. And then this idea of providing education and information to the patient and the families, I think this is one area where you could definitely expand or strengthen this in your practice. Being able to do this not only on admission or with a change of condition, but really at the quarterly assessment and at the family, resident and family meeting is a really terrific time to incorporate this. And so being able to talk to residents and families about the fact that there are age-related bladder changes. And so because of this, there are reasons why you might be struggling with bladder function, but that there are also things that we can put in place to help you. And some of those self-care strategies really include avoiding things that are an irritant to the bladder. And so bladder irritants cause an increase in urgency and frequency, and in some residents, even an increase in incontinence. And so those things can include caffeine, alcohol, and artificial sweeteners, particularly NutraSweet. Now, not everyone is sensitive to all of those things in that way, but keep in mind that even with the use of caffeine, so for example, coffee in our residents, even reducing their intake of caffeine by one serving may positively impact on their bladder function. So it doesn't always have to be an all or none kind of situation, but paying really attention. Maintaining adequate fluid intake becomes really key. Oftentimes what we see is that people try to self-manage by limiting the amount of fluid because they think if I don't drink as much, then I won't have to go to the bathroom as much, and then I won't risk being incontinent. Well, sadly, that results in concentrated urine. That concentrated urine then acts as a bladder irritant and actually contributes to the incidence of urgency and frequency as well as a risk of incontinence. So really helping them understand the importance of an adequate fluid intake and support for toileting is really, really important. In our residents who smoke, encouraging smoking cessation is really key. Not only is nicotine a bladder irritant, but the chronic cough that often goes with smoking can increase the risk of stress UI. And so again, that's a behavioral strategy that you can address. Avoiding constipation. And so one of the things that we've got all over the news now, or not even the news, all the commercials, is all about the constipation issues related to the use of different narcotics. Well, a lot of our frail elders are on medications that cause constipation, not just the use of a narcotic, but also that have high anticholinergic properties. And so as a result, being able to proactively put bowel plans into place that will help them address these constipation issues and maintain their overall bladder infection or function are really important. Paying attention to weight. We have a lot of older adults that carry weight through their middle section. That weight puts pressure on the bladder and contributes to a risk of stress UI. And what we know is that even as little of weight loss as 5 to 10 pounds can improve bladder infection. So really focusing on healthy eating and movement towards a more healthy weight becomes really important. I do think for the most part we do a pretty good job of trying to help people dress more comfortably and avoiding restrictive clothing, moving to things like suspenders or an elastic waist pant versus belts and zippers are an example of that. We also try to really consider somebody's ability to access the toilet, the assistive devices they might need to use, and then being able to really negotiate proactively with the CNAs who are going to be helping them toilet is another really important strategy. Managing chronic health problems, certainly diabetics who are not well controlled, high blood sugars do increase the risk of urinary incontinence. COPD with increased coughing and respiratory changes that go with that increase the risk of stress UI. And then in general, maintaining good perineal hygiene, keeping the area clean and dry, wiping from front to back is a very basic but important strategy. So kind of to expand on in the time that we have left, what else can you do? Certainly in your individualized care plan, including and assessing for risk factors and putting prevention strategies in place are really important. So we just talked about lifestyle factors. We've talked about constipation. We've talked about cluing into the fact that a resident is female and that they may be more at risk for certain kinds of incontinence. And also in our male residents who have enlarged prostates or who have had prostate surgeries, they may be more at risk. So being able to identify those and then proactively address that, I think, becomes really important. Medications, we all know the De Beers list there's some days where I go, are there any medications any of us should be taking? And I often think, no, we shouldn't. But there are certainly medications that are needed. What you really need to pay attention to are medications that are being added or taken away and how that's impacting on bladder function, as well as medications that are being adjusted, with doses particularly being increased in relation to diuretics. That's a very, very common example. Cognitive impairment, neurologic disease, diabetes, heart failure, arthritis, and depression and anxiety are all significant chronic illnesses that have the ability to impact not only function, but also motivation to toilet, because sometimes those chronic illnesses really wear people out. And the treatments for those illnesses are very difficult. And so if you've got multiple chronic illnesses, and let's face it, our residents in long-term care settings have, a minimum of 9, I believe, is the average right now. That's a lot of chronic illness. And so there's a lot of factors that you just need to clue into and kind of be aware of and look at where you can proactively manage and address changes. So engaging in nursing assessment on admission, if there's one thing that you want to add that you aren't currently doing, this is a terrific place to do it. And what I've provided you with are evidence-based questions that have been shown to improve patients' reporting or discussion of their bladder function issues upon admission. So let me give you an example. If you were to do a history with me and you said, Kelly, do you have a history of domestic violence? I'm probably not going to say yes to that, and that's consistent with sort of the national average, because most people don't identify themselves in that situation, or they're embarrassed and don't want you to know. And so, but if you ask me, are you in a relationship where you feel like you're being treated well, I am much more inclined to have a discussion with you. The same is true with urinary incontinence. So if you said to me, Kelly, do you have urinary incontinence? I'm probably not going to give you my best answer. But if you said to me, do you ever have any problems with your bladder? I can't tell you how well this question works. It works so well, you just can't believe it. You just have to try it. If you're not doing it, you're going to be amazed. But then being able to expand on that and just asking, are you ever losing urine when you don't want to? Or if you cough or sneeze or get up for a chair, from a chair, do you ever leak? Do you wear anything to protect your clothes? Do you leak on the way to the bathroom? Those questions have been shown to be really, really helpful. So if you don't have specific questions on your intake form, these would be really terrific things that you can add right now that will begin this assessment process and change how you develop your plans of care. The other thing that I want you to do is I want you to remember to ask about bladder function and continence. When our residents are moving from an acute care setting back to long-term care, or rehab setting back to long-term care, or from the community, in those transitional care times, it's really important to get not only updates on all the other changes that have occurred, but what's happening with bladder function. Because we've all had incidences where we've had residents who were continent with a good toileting plan. They go into an acute care setting and they come back in worse shape than when we sent them in. And a lot of that has to do with traditional protocols that are in place and the fact that, bed rest is being implemented and there's a change in function and mobility. So it's really important to ask about that. And then, of course, reviewing medical records. Weekly nursing summaries are really important, so have conversations with your primary nurses as far as what they're seeing and what their assessments are really reflecting, and make sure that their assessments are documenting bladder function as well as how well toileting plans are working, and identifying whether or not there's been any change of condition. And if there has been a change of condition, is continence status being addressed as part of that? Because this is a perfect time when somebody's had a change of condition to implement your 3-day bladder diary to be able to assess how significant that change actually is in impacting bladder function. And in addition, Section H on the MDS assessment tool also asks us to really address this at a quarterly way. I'm getting the high sign here, 5 minutes left, so let me go a little faster. Bladder diaries, I'm happy to answer questions about these, but I did give you 2 that I think work really, really well. And the reason why I think they work really well is I have good success once the CNAs understand the importance of bladder diaries, these are bladder diaries that they seem to really like. And that's the key, is you really want to pick a bladder diary that's easy for you to use in your setting. I would encourage you that once the data has been collected, that the primary nurse or the MDS nurse or whoever's doing it, looking at those diaries, because it's not enough to collect them. You need to look at them, and I would take a yellow highlighter, and I would go through and I would highlight all the wet episodes. And I would look for patterns over that 3-day period. Now, I say 3 days because if you look in the literature, there's a wide range of the number of days, but the consensus is that 3 days really gives us the best, most accurate snapshot. 1 day, I'll take it if that's all I can get, but really, once we get past 3 days, it's hard for people to be able to continue to document that accurately in an accurate way. So for accuracy, this 3 days really seems to be kind of the magical window. If you're lucky enough in your long-term care settings to have a bladder scan, this is really, really helpful. This really helps you when residents are particularly symptomatic, especially when you're assessing for symptoms of incomplete bladder emptying, which can also include urgency and frequency. And so you're trying to really differentiate between symptoms of urinary tract infection, bladder function, all these different types of things. So bladder scans are an important tool, and that's actually a whole conversation that we could have, again, an expanded conversation at another time. I would really encourage you to examine your residents, and I don't mean to imply that you don't, but what I find is that nurses aren't always comfortable doing all aspects of an exam related to bladder function. So what I'll say to you is your assessment of your exam not only includes cognition, mobility, and function, but also a good abdominal exam to make sure that they're not distended, both bladder distension as well as bowel distension. Listen to bowel sounds, really get a sense of what's going on abdominally and in relation to the GI tract. Also, being able to do a urogenital exam. So certainly the exam that I do would most certainly be a little bit more in-depth than what you would do, but it would be really important if you could take a look at that urogenital area and assess the skin for changes, particularly looking for redness and irritation and leaking related to continence-associated dermatitis. Also just taking a look at the tissues in general for women, which tend to be pale and thin and fragile. And when you see that, you know that they have a very low or hypoestrogen effect, and so they're going to be much more at risk for urinary tract infections and incontinence. Also structural changes, because you shouldn't be able to see any of the pelvic organs at the opening of the vagina. And when you're looking, you'd be amazed at how many times you do see pelvic floor relaxation with pelvic organs, at the opening of the vagina. So that's something that you definitely know to refer to have further assessment for. And then this loss of pelvic tone and being able to really assess whether there's an observable loss of urine with position change or coughing. And you can do that really easily by just asking them to cough or sit up a little bit at the same time that you put a paper towel across, with a little pressure from your hand. And when they do that, when you take your hand away, if the towel is wet, they have a loss of pelvic floor tone. Being also to do a rectal exam to assess for presence of stool as well as rectal tone, and then whether or not there's any changes in sensation reflected in a neural exam. So once you've collected your history, once you've taken a look and included those objective components in your assessment, we want to really put in place some continence goals. And our continence goals are really designed around maintaining dignity and quality of life, individualizing a continence plan of care, reducing the risk of urinary tract infections, reducing the risk of falls, and maintaining skin integrity. You can certainly partner with the resident and the family to put this plan in place. There's many interventions, and we've talked about these already. They're listed here for you again, as well as behavioral interventions, particularly related to toileting regimes. So I want to talk about those a little bit more. Partnering with residents to achieve improved continence is really significant. I don't know why, but we have trouble sometimes just talking with cognitively able residents about what would be helpful to them in helping them stay drier or to get to the bathroom. And just reassuring them that you'll work with them to help them stay dry the best you can. And then this idea of following through, and this certainly involves the CNAs and helping them have a better understanding of continence issues as well, and being able to communicate from shift to shift as far as what's happening with toileting. We've talked about addressing behavioral and lifestyle factors, so I'm not going to go through that again. But in your toileting plans also, not only would those include behavioral and lifestyle factors, but also being able to recognize that there's different approaches that can be used. And what you might use during the daytime may not be the same as you use at nighttime, and so it's absolutely appropriate to be able to differentiate that in your plans of care. So the types of toileting regimes we talk most commonly about are independent, scheduled, prompted, and social continence. And independent is really that person who's able to toilet themselves, manage their clothing, and are confident in social situations. Scheduled toileting is really designed, and this is where the Bladder Diary becomes helpful because you get a chance to see the kind of a snapshot of their voiding schedule or what works for them. Usually people go to the bathroom every 2 to 3 hours. For some frail elder adults, they have trouble holding urine for 3 hours. They're much more likely to be at 1.5 and 2 hours, which is pretty normal given their chronic comorbidities. And what we frequently say in the care plan, especially after we have completed their Bladder Diaries, is using language that reflects the resident's routine and their activities rather than one of the long-term care settings. So an example would be, toileting upon rising, after meals, after rest, before bed, and then certainly tailoring that for what goes on at night. Prompted voiding I talked with you about already, and this idea that it works for those residents with mild dementia or cognitive impairment, really prompting them, reminding them that we're scheduled, you just went, oh, okay, I did, all right, but I'll come back in 30 minutes and I'll be able to help you. Assisting them as needed, again, being able to give positive reinforcement and this reminder and following through that you will be back. Bladder retraining is something that we do pretty commonly after we've taken out catheters, but you can also do this when somebody has significant urgency and frequency. And what I'll say is with bladder retraining, you do have to have somebody who's motivated and cognitively able. And so it's this combination of deep abdominal breathing, pausing, distracting themselves, and then being able to contract the pelvic floor muscles in 4 or 5 quick flicks. And over time, this does work for some residents. Improvement will occur. Social continence is one of the other takeaways that I want you to have today. And with social continence, this is really about those residents that are experiencing intractable UI. They're usually at the, their chronic comorbidities have progressed to the point where, they're not able to toilet anymore, that they just are really experiencing intractable incontinence. We refer to this frequently as check and change. And what I'm going to ask you to do is to begin to avoid this language. Again, it's a dignity issue, and I want you to really think about using the term social continence, because social continence really fully captures the depth and breadth of the type of nursing care that you're offering to this resident at the end stage of his or her life. It does include the use of an appropriately selected absorbent product, and your goals with this are to keep the resident as dry and comfortable as possible, odor-free, and their skin in good condition. So imagine going into a family meeting and saying in that meeting, getting rid of the word check and change and replacing that with, we've put a continence plan in place for your loved one. that is called social continence. And social continence means that we keep them dry, odor-free, and as comfortable as possible while maintaining their skin condition. We know that's important to you. If you're a family member who gets a chance to hear this and have this conversation with you, you're going to feel so much better about the caliber and the quality of nursing care that's being developed than using language like check and change. Also, I've talked with you about the importance of using the appropriately selected absorbent product. We do have residents who do all kinds of creative things with their absorbent products, wearing 3 and 4 at a time, and pads inside briefs and briefs inside pads, and it really becomes quite the show sometimes as far as trying to figure this out. And what they're really trying to do is problem solve this. They're really trying to come up with a way that they can manage this cost effectively. And so this is a really good opportunity for you to be able to sit down with them and incorporate these components. Again, I've talked with you repeatedly about supporting function and mobility as a strategy. Pelvic muscle exercises, again, if you have a resident who's cognitively able and who is motivated, this is something that physical therapy can work with them on. This is also something that we've been able to incorporate into restorative nursing. I've got one setting that I consult in where the CNA struggled with bladder issues and learned how to saw the value of pelvic muscle exercises, and so now when she does restorative nursing, she also offers pelvic muscle exercises for those who want to do that, and I've worked with her on the correct technique for doing that. So there's some pretty creative stuff that you can do. Again, this idea that the quarterly review really provides for you an opportunity. It needs to be thought of as more than just a task you have to get done. It's really an opportunity to fully assess that whole person from all aspects, but keeping in mind that if there's changes in continence status, you need to look at bowel function, you need to look at cognitive function, mobility, and skin integrity. And again, using using your Bladder Diaries as a tool. So, my summary here. You definitely, I can't encourage you enough to really reach out and use your nursing expertise and skills and knowledge in supporting residents in the care settings that you're in their continence. Acknowledge that UI impacts their quality of life and that you certainly want to help them, and you can do that by identifying residents who are at risk and putting prevention strategies in place. You can identify, you can not only identify changes in condition, but put assessment strategies in place. You have the opportunity. Long-term care shines in this area. Every other health care setting is struggling with how to capture the lived experience of someone's health, but long-term care has done it through your care plan and your use of nursing diagnosis as a part of the care plan that captures the lived experience, and you can do this also with bladder function. And then don't forget to add that additional layer of more fully engaging residents and family in education and health behavior change strategies, and then making referrals and requesting consults as appropriate and needed. The benefits to all of this is that continence care respects resident dignity and quality of life. It addresses issues related to quality, safety, and cost of care, and right there you are playing a key role in contributing to the triple aim of the initiatives of our overall healthcare system. In addition, and most importantly, the family and the resident feel supported and confident in the care. And one of the really terrific benefits is that CNA workload can often be reduced and job satisfaction improved. So in conclusion, I just want to say thank you all for everything that you do for frail elder residents. I know it's just a terrific opportunity to be able to share your skills and expertise and improve their lives. And I love the fact that long-term care settings are truly nursing homes. I like that a lot. So thank you for your time today. I really appreciate it. And Emily, what's the thought on questions here?
I don't see any in the chat or the Q&A.
All right. Well, and if there are, you have my phone number for my office as well as my email, and you certainly have Emily's contact information as well at MetaStar, so we'll be happy to help you with that. But thank you so much for your time today, and I hope that this has given you some ideas and some directions to take your practices when addressing continence.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.